Hello, and welcome to this mini-gem entitled Always Use Protection for the Bones, a short guide for junior doctors on how to assess and manage fracture risk on the wards. My name is Dr. Peter Brock, and I will be talking you through this topic today. So I have 3 learning outcomes for this mini-gem. Firstly, I want to give you some tips on how to identify which of your inpatients are at high risk of fracture. And then I hope to help you understand about the purpose of DEXA scans and frac scoring and how these can help you make decisions about the treatment that you give your patients. Finally, I'm going to discuss what treatment options are available and what you should be telling your patients about them before starting them. So why did I think it was important to talk about this topic? Well, I've led ward rounds myself and casually thrown into the plan, can you do a frac score for me? At which point my team has given me a look of mild exasperation, and it struck me that perhaps this is something we ask of our team without explaining why and with an expectation that these acronyms actually mean something to them. Not only that, such assessments can take us down the road of prescribing multiple new medications for our patients, and it's important to consider whether they actually provide benefit, given they're not the easiest drugs to tolerate. So why should we think about bone protection? Well, the number of fragility fractures is high, as is the mortality and financial cost associated with them. We do have medications available that can reduce the frequency of these fractures, and those medications are what I refer to when I talk about bone protection. However, we cannot just blanket treat everyone. Doing so would ignore the side effect profile of these treatments. Instead, we must look to identify which patients are most likely to benefit from bone protection, and that is where a little thought, and hopefully this mini-gem, will come in handy. Note that bone protection medication is not the only means for reducing fracture risk. It's also important to consider lifestyle interventions for your patients. Examples of these include increasing the level of physical activity, stopping smoking, reducing alcohol intake to less than 2 units a day, ensuring they have an adequate dietary calcium intake and vitamin D level. Falls prevention is obviously a huge deal when it comes to preventing fragility fractures. The topic deserves a mini-gem in itself. As doctors, we should be considering what impact the medications we give can have on falls risk, as well as look to address reversible impairments in vision, hearing, cognition and other physiology that can cause falls. Just as important, though, is that we engage with our multidisciplinary team, including physios, occupational therapists and fall specialist nurses. Both in hospital and in the community, they can offer a vast array of strategies and techniques for falls prevention. Now, for the rest of the mini-gem, I'm going to be focusing on the bone protection itself. It's important at this stage to remind ourselves that osteoporosis is the pathology that we are targeting with our bone protection treatments. The loss of bone mineral density leads to increased fracture risk. While osteoporosis is a pathological phenomenon, we diagnose it through a radiological measurement, namely by doing a DEXA scan and looking for a bone mineral density of more than 2.5 standard deviations worse than the bone mineral density of a healthy young woman. It's in guidelines for the management of osteoporosis that we find advice for deciding who to give bone protection to on the wards. Both NICE and the National Osteoporosis Guidance Group have guidelines to advise us on who we should assess for fracture risk when we see them on the ward. This is important because it's patients with high fracture risk that we would consider giving bone protection medication to. Their advice differs slightly, but identifying risk factors for fracture is key to both. Here is a list of fracture risk factors. I would encourage you to take a moment to pause the mini-gem here and take a look at these. This is because it's these risk factors that you're going to be looking for in your patients on the wards. When you see them, you need to think, should I assess this patient's fracture risk? Because they might benefit from bone protection medication. Note that secondary causes of osteoporosis include rheumatoid arthritis, Parkinson's disease, and type 1 diabetes. So once you have found your patient who has a risk factor for having a fracture, what do you do next? How do you quantify their risk? Well, thankfully, we have the FRAX tool available. This online tool uses epidemiological data and some basic information about your patients to give you an idea of their 10-year fracture risk. I'm going to talk you through it now. Here is what you'll be presented with when you first go to the website. As you can see, I've entered some made-up patient details into the FRAX calculator here and hit calculate. It then gives me a 10-year probability of fracture for both major osteoporotic and hip-type fractures. That's all very well and good, but what on earth do I do with those numbers? Well, thankfully, you can now click on the View NOGG Guidance button, and it will give you an indication of what to do next.
When you click that button, you'll be taken onto this web page, which plots your patient's age against their fracture risk and tells you what to do next. If it hits the red section, then it would advise that you consider starting treatment. If it hits the yellow section, then it would advise that you do a DEXA scan to measure their bone mineral density. The result of this can either then be plugged back into FRAX to get a more accurate fracture risk score, or if it proves that they're osteoporotic on the scan, you can offer them treatment anyway. And then if they're in the green zone, you can just offer them lifestyle advice at this stage. All in all, a very handy way of deciding which of your patients you should offer bone protection medication to. If you do decide to do a DEXA scan, you'll typically get an image like this back. What you want to look for is the T-score, which is the comparison of the bone mineral density to that of a young adult. You'll often also get a Z-score, which is a comparison with an age-matched person. For a diagnosis of osteoporosis, you're looking for a T-score of minus 2.5 or worse. Note that you might also get given a T-score from the vertebra, although these can be falsely reassuring because a crush fracture can actually increase how dense the bone appears, while there may still be osteoporosis present. Do we ever offer bone protection without doing a DEXA or FRAX score first? Well, yes, we do. Both NICE and NOG are like circumstances where, with a prior fragility fracture, you could offer bone protection without further assessment. If you're interested in the evidence base behind this, then look at part 11.10 in the NOG guidance. So if you decide your patient would benefit from bone protection medication, what treatment would you offer them? Well, the majority of patients you'll be offering calcium and vitamin D supplementation to. This is because adequate levels of these are required for your other bone protection medications to work, and they potentially have a small reduction in hip and non-vertebral fracture risk as well. The other typical first-line medication in bone protection is a bisphosphonate, typically alendronate, but there are other versions of bisphosphonates available depending on what side effects the patient can tolerate and their renal function. Denosumab is a monoclonal antibody that is used for bone protection and is another treatment option that may be considered. The key is to discuss which treatment will be best with your consultant and have the patient's renal function handy. Once you've decided on what bone protection you're going to offer the patient, it's important you let them make an informed decision. In particular because some may feel that if they're not at risk of falling, that they're unlikely to sustain a fracture. Here are some ideas of the number needed to treat for these medications and the common side effects to warn people about with oral bisphosphonates. In addition, you're going to want to check that they've got a good dental history because bisphosphonates increase the risk of osteonecrosis of the jaw. If in doubt, ask them to see a dentist before you start the treatment. In addition, it would be a good idea to inform them that their treatment will be reviewed after 5 years to see if it's worth them carrying it on. Also, these are the instructions for how a patient has to take alendronate. As you can see, they're quite complicated. Make sure they can comply, and if you don't think they can, consider one of the alternative forms of the medication. That brings the mini-gem to an end. In summary, you should be identifying patients that are high risk for fractures as part of your assessment on the ward. Do a FRAX score, and then prior to starting any treatment, make sure you discuss the pros and cons with the patient themselves. I hope you have found this mini-gem useful. Here are my list of references from the talk. If I was to encourage you to read one, it would be the National Osteoporosis Guidance Group Guidelines. Thanks for listening.